1 in 5 people over the age of 55 will lose all their teeth. Most of them will make the wrong choice, not because of a bad doctor, but because they didn't know one key fact. Here is that fact. Complete tooth loss is not the end. I want you to remember this phrase, because most people who come to me with this diagnosis think exactly that. It's over. No, this is a crossroads. Two paths. A removable denture, the classic option, and implant-supported dentures, the modern one. Both work. Both have patients who are happy, and both have patients who regret their choice. The difference is information. What you're told before you decide. Today, I'll tell you everything. Not an advertisement. Not a generic list of pros and cons from the internet. The real picture. Anatomy. Cost. Psychology, yes. That too. Let's begin. Let's start with the first path. Removable dentures. Here's how they work. An acrylic-based pink, matching the color of the gums. On it, artificial teeth are attached, usually plastic. The denture sits on the gums. That's it. No attachment to the bone. No roots. This is important. Remember it. The denture stays in place due to its fit against the gums, saliva acting as a natural adhesive and, for many people, a special adhesive cream. Now, about chewing. Healthy teeth transfer chewing force directly into the bone. It's powerful. It's stable. A removable denture distributes that same force onto the soft tissues of the gums. The result? Chewing efficiency with a removable denture is about 15–20% of natural teeth. 8 out of 10. You chew, but not really. This changes nutrition. It changes digestion. It changes quality of life. This is an opinion. This is physics. Now let's talk about what happens next. 1 week later, 1 month, 1 year, after tooth extraction, the gums begin to change shape. This is normal biology. Bone without load remodels. It resorbs. The gums follow it all settles down. A denture that fit perfectly on the day it was made can start to feel loose within 3 months. Sore spots appear. Pain while chewing. That constant feeling like the denture might slip or fall out. What do? Relining. This is a procedure where the inner surface of the denture is adjusted to match the new shape of your gums. It's typically needed every 1 to 2 years, sometimes more often, and every 5 to 7 years, the denture usually needs to be remade entirely. Materials wear out. Your bite changes. Patients who think, I'll get a denture and forget about it, often come back a year later with pain and disappointment, because no one explained this to them in advance. Psychology. On Reddit, a user posted, mental health problems after implants, 15 upvotes and 33 comments in 3 days. People wrote, no one warned me about the adaptation period. I didn't recognize myself in the mirror. This is reality for both dentures and implants. Losing your teeth is losing a part of yourself. And adapting to a denture is not just physical, it's psychological work. The first month is the hardest. A constant feeling of a foreign object, changes in speech, discomfort while eating. By the 2nd to 3rd month, most patients adapt. But one real comment from a forum, my only regret is not doing it sooner. I don't wake up with gum pain every morning anymore. Just make sure you have a good prosthodontist. Here's the truth. For many people, a removable denture is freedom, the end of pain, the end of endless treatments, and the beginning of a normal life. The key is knowing what to expect. A removable denture is the right choice in specific situations. First, significant bone loss when implants would require major bone grafting. Second, systemic conditions, uncontrolled diabetes, severe cardiovascular disease, immunodeficiency. Third, financial limitations. A denture can cost 5 to 10 times less than full implant-supported rehabilitation. Fourth, advanced age with serious comorbidities. This is not worse or better. It's a different solution for different circumstances. A good doctor doesn't sell implants to someone who needs a denture, and doesn't leave someone in a denture when implants could change their life. We've covered the first path. Now the second. Implants. And here's one fact I've been saving on purpose. It's about your bone. And most people only learn it when it's already too late. Watch closely. Let's start with the basics. What is an implant? An implant is not a fake tooth. It's an artificial root. A titanium post is placed into the bone. Then comes osseointegration. The bone literally grows into the microporous surface of the titanium. This process takes anywhere from 2 to 6 months. After that, an abutment is placed on the implant, a connecting piece, and on top of it, a crown, the visible part, the tooth. Why is this fundamentally different from a denture? An implant transfers chewing force directly into the bone, just like a natural tooth. Chewing efficiency, about 90% of natural teeth. That's the difference between eating something and eating properly. An apple? Yes. Nuts? Yes. Steak? Yes. A removable denture doesn't allow that. Now the key concept for patients who have no teeth at all on 4. This is not 4 implants replacing 4 teeth. It's 4 implants supporting an entire arch of 10-12 teeth. How is that possible? 2 front implants are placed vertically. 2 back implants are placed at a 45-degree angle. This angle allows the use of the maximum available bone, even in cases of bone loss. And here's the key point. In many cases, temporary teeth can be placed on the same day. The patient comes in without teeth and leaves with teeth. After 3 to 6 months, once full osseointegration has occurred, a permanent prosthesis is placed, typically made of zirconia or metal ceramic. All on 6 follows the same concept, but with 6 implants instead of 4. More support points, higher load capacity, better long-term prognosis. Who should consider all on 6 instead of all on 4? Patients with greater bone volume, higher chewing forces, or those who want maximum long-term stability. Honesty goes both ways. All on 4 is not suitable in several cases. First, active smoking. Nicotine significantly reduces blood supply to tissues. The failure rate of implants in smokers is 2 to 3 times higher. Some doctors refuse treatment to smokers or require at least 3 months without smoking before surgery. Second, uncontrolled diabetes. A high glycated hemoglobin means poor healing and a higher risk of periimplantitis. Third, a history of radiation therapy to the head and neck. Bone that has been irradiated has reduced blood supply. Fourth, the use of bisphosphonates medications for osteoporosis. There is a risk of jaw osteonecrosis. This doesn't mean never. It means consult a doctor first about these specific factors. A good implantologist will tell you no, or not yet prepare first before taking your money. We've covered both paths. But I promised you one fact, the one that changes the decision. It's about bone, about what happens to your jaw while you delay treatment. This is part 3, the most important one. Here's the fact no one talks about in ads. When teeth are gone, the bone goes with them. Not a metaphor. Physiology. The jawbone exists to hold teeth. That's its function. When the function is gone, the bone receives a signal. I'm not needed. Resorption begins. Atrophy. In the first year after tooth loss, about 25% of the height of the alveolar ridge, the part of the bone that held the roots, is lost. By year 5, up to 50% of the volume. By year 10, the facial profile changes. The lower third of the face collapses. Lips lose support. A characteristic aged look appears not from age, but from loss of bone support. And this happens even if the patient wears a removable denture. Because a denture presses on the gums, not the bone. The bone receives no functional load. Resorption continues. That's why a denture that fit well in the first year starts to feel loose after 3. Not because it's a bad denture, but because the bone is gone. Why does this fact change the decision? Because it changes the cost and complexity of implant treatment. If you come in 6 months after tooth loss, the bone is still there. All on 4 can often be done without grafting, a standard procedure. If you come in 3 to 5 years later, bone has been lost. Bone grafting is needed, and additional surgery, additional materials, and another 3 to 6 months of healing, plus added cost. If you come in after 10 years, bone loss can be critical. Procedures like sinus lifts, guided bone regeneration, and complex multi-stage surgery may be required. Not every clinic will take the case. Do you see what's happening? Delaying the decision isn't saving money. It's accumulating complexity. That's why an implant is not just a tooth. An implant protects the bone. When chewing force is transmitted through the implant into the bone receives a signal. I'm needed. Resorption slows down, or can even stop. That's why patients with implants look different after 10 years compared to those with dentures. The first group preserves the volume of the lower third of the face. The second develops the characteristic atrophy. This isn't about aesthetics. It's about bone health. And this is something you won't find in advertising brochures. Now you know more than most patients do at their first consultation. What matters next is how to use this knowledge. A clear, practical algorithm. 4 questions. Question 1. Do I have any contraindications to surgery, uncontrolled diabetes, bisphosphonate use, or a history of radiation therapy to the head? If yes, start with a consultation with the appropriate specialist. Implants may still be possible, but only after proper preparation. If no, move on. Question 2. How much time has passed since I lost my teeth? Less than 3 years, there's likely enough bone, and all on 4 may be possible. More than 5 years, you'll need a CBCT scan to assess bone volume. Question 3. What is my financial horizon? If you need a solution now with minimal cost, a denture today, implants in 1 to 2 years, that's a valid strategy. If you can invest once, all on 4. Question 4. Am I psychologically ready for surgery? This is a serious surgical procedure. Anesthesia, the day of surgery, a healing period. You need internal readiness, not, they told me I should, but I understand why I'm doing this. And 5 questions you should ask your doctor word for word. First, what is my current bone volume, and do I need bone grafting? Second, which option, all on 4 or all on 6, do you recommend in my specific case, and why? Third, what will happen to my bone if I choose a removable denture and don't get implants for the next 3 years? Fourth, show me my CBCT scan. Where exactly is my bone deficiency? Fifth, how many implant procedures do you perform per month, and can I see examples of your clinic's work? A good doctor will answer all 5, gladly, because a good doctor wants an informed patient, not a frightened one, and not a blindly trusting one. If you're watching this video, and you, or someone close to you, has complete tooth loss, here are 3 steps to take today. First, don't delay the consultation. Every month means more bone loss. Second, ask for a CBCT scan at your first visit. Without imaging, there is no treatment plan. The scan is a map. Without it, the doctor is working blind. Third, get a second opinion. Not because the first doctor is bad, but because with a decision like this, a second opinion is insurance. Please save this video to your bookmarks. Share it with your friends and family. Leave a comment. Your experience might help someone else make the right decision. Subscribe to the channel so you don't miss the next breakdowns. See you soon.